Are we good to go? Okay, thank you. Hello, everyone. My name is Corey Bray. I'm a PGY1 pharmacy resident here at Erlanger Health System in Chattanooga, Tennessee. Today, I'll be talking about advancements in acute stroke care. I'm specifically going through the updated 2019 ischemic stroke guidelines and looking at Anti-Platelet and mechanical thrombectomy updates since those guidelines have been published. I have no financial or other disclosures that would impact the integrity of this presentation. The objectives of this presentation are as follows: identify signs and symptoms of acute ischemic stroke, describe current clinical guidelines of acute ischemic and hemorrhagic stroke management, analyze literature supporting mechanical thrombectomy as a standard of care for acute ischemic stroke management, and compare and contrast the efficacy and safety of Alteplase and Tenecteplase for the management of acute ischemic stroke. For a little bit of background in stroke, 1 out of 6 cardiovascular disease deaths are attributed to stroke. Someone in the US has a stroke every 40 seconds, and the death occurs every 4 minutes currently. And around 800,000 people in the US have a stroke annually. The most common type of stroke is an ischemic stroke at 87% versus 13% of strokes being hemorrhagic stroke. And then stroke-related costs total around $46 billion in the U.S. Between 2014 and 2015, and what is one of the leading causes of long-term disability in U.S. citizens. The risk is nearly twice as high in the African-American population versus Caucasian as well. As I mentioned earlier, there are 2 main different types of stroke. The first and most common being ischemic, which is a cerebral artery blockage causing a tissue oxygen supply mismatch. You can break down ischemic strokes into 3 different types of ischemic stroke. So you have thrombotic, where there's a thrombus that blocks the brain vasculature, an embolic, where an emboli is formed outside of the brain, such as atrial fibrillation, and then a lacunar stroke, which is an occlusion of the small penetrating branches of the middle cerebral artery, vertebral or basilar artery of the lenticulostriate vessels. And then the lesser of the common 2 strokes are hemorrhagic, where you experience extravesicular blood in the brain, causing an oxygen mismatch as well. Most common risk factors for acute stroke are all of your basic modifiable risk factors, such as hypertension, hyperlipidemia, smoking, diabetes, and obesity. One of the most common ways to prevent stroke is by changing these modifiable risk factors and controlling these disease states. Signs and symptoms of acute stroke include unilateral loss of sensation or motor ability, aphasia and dysarthria. Aphasia being cannot forming words, dysarthria being slurred or slowed speech, blurry vision, loss of coordination, balance, and gait, and then severe headache. I'd be remiss if I didn't include one of the most common things you would see. It's on our badge buddies. It's posted everywhere around the hospital, and that is being able to identify a stroke. People use BFAST or FAST. I just included the American Heart Association acronym of FAST. F being a facial droop, so asking if the person can smile and noticing if one side is drooping versus the other. Looking at arms, making sure that they can raise both, or if there's one that is different. Asking them to speak a simple phrase and trying to notice if there's a slur in speech or difficulty forming words. And then time. One of the most important factors in treating a stroke is time. Calling 911 if any of the above occur, and getting them to the hospital as soon as possible. The National Institute of Neurologic Disorders and Stroke, abbreviated NINDS, have published time goals throughout history regarding different goals of care with stroke. So basically, when a patient has a stroke, they have different goals that they want to meet as far as time. So they want the patient to see a physician within 10 minutes of stroke onset, which is extremely difficult, but this is something that they want to see as soon as they get to the hospital. They want to see a physician within 15 minutes, be seen by the stroke team, within at least 20 minutes being in the CT, and within 45 minutes having an interpretation of that CT scan, and at least within 60 minutes of being brought through the door to given a medication. Less than or equal to 45 minutes is ideal, but the goal is less than 60. And then door to stroke unit admission is less than or equal to 3 hours. So again, time is extremely important and key in treating stroke. So we'll take a minute for an assessment question. What is the most common type of stroke? A, ischemic, or B, hemorrhagic? A, ischemic, almost 90%. The next portion, I will go through the guidelines that have been most recently published for stroke, and I'll start with the 2019 update to the 2018 ischemic stroke, acute ischemic stroke guidelines published by American Heart Association. The first part of the guidelines that I'd like to touch on are diagnostics. Like I said earlier, all patients with suspected stroke should receive emergent brain imaging upon hospital arrival. Gold standard is a non-contrast CT, is extremely effective at excluding intracerebral hemorrhage before giving a thrombolytic like Alteplase. Typically, an MRI is not necessary, and it should not delay the administration of any medications. So ruling out hypoglycemia is extremely important as well, and I'll touch on some more information about that. And then being able to perform non-invasive intracranial vascular study during initial imaging if the patient is eligible for mechanical thrombectomy, and that's referring to an angiogram, to make sure that they will be eligible for a mechanical thrombectomy. And like I said earlier, nothing should delay the administration of IV Alteplase if the patient's eligible. As far as treatment, there are two first-line standard therapies, first being thrombolytic therapy specifically, and these guidelines, IV Alteplase or recombinant TPA, and then mechanical thrombectomy is your other gold standard first-line treatment. First, I'll touch on IV Alteplase. It was initially FDA approved for the treatment of acute stroke in 1987. Is recombinant tissue plasminogen activator. So it's not genetically modified, it's just what humans actually produce. The dosing is listed here, 0.9 mg per kg with a max of 90, infused IV over 60 minutes with 10% of that dose infused as a bolus over 1 minute. Most common adverse effects include bleeding. Angioedema is something that is listed, and it's not quite as frequent as bleeding, obviously. And then there are risks for reembolization due to the half-life being so short. I have the cost listed down here. Specifically for our institution, the wholesale acquisition cost is around $8,500, and then 340B being right at $1,900 per 100 milligram vial. There are different eligibility criteria for Alteplase. So there are inclusion criteria depending on the patient and the stroke. Within 3 to 4.5 hours of symptom onset would have a patient included in eligibility for IV Alteplase. They need to be at least 18 years or older, and then excluding ICH as the primary cause is extremely important. There are absolute and relative contraindications to the use of IV Alteplase, and I'll get into those briefly. First, we'll talk about the absolute contraindications. This is a compilation of different lists provided by the package insert in some publications. Obviously, the primary absolute contraindication being a current intracranial hemorrhage or a subarachnoid hemorrhage. You obviously don't want to give someone a thrombolytic if they are currently bleeding. Whether that be in the brain or internally somewhere else. Intracranial, intraspinal surgery or serious head trauma within the past 3 months, a bleeding diathesis, blood glucose less than 50 mg per deciliter, and current severe uncontrolled hypertension greater than 185 over 110 millimeters mercury despite treatment with antihypertensives. Relative contraindications can be broken down between the hours of 0 to 3 and then the hours of 3 to 4.5. So this is an extensive list, but some of the primary ones that I wanted to touch on are minor or rapidly improving symptoms that would maybe clue you into that it's not a stroke. Pregnancy, seizure at onset with postictal neurological impairments, major surgery or serious trauma within 2 weeks, recent urinary tract hemorrhage within 3 weeks, arterial puncture at non-compressible site within 7 days, usually being a spinal tap, or intracranial arteriovenous malformation or aneurysm. Between the hours of 3 to 4.5, there are a few more criteria that you would want to think about before recommending Alteplase. Age greater than 80, the NIHSS, which is a scale that determines the severity of stroke, 0 being not severe at all, and the higher the number, the more severe the stroke is. So that number would be greater than 25, a history of diabetes and prior stroke, and taking oral anticoagulants regardless of INR. Next, I'll move into eligibility for mechanical thrombectomy. Like I mentioned earlier, the evaluation for mechanical thrombectomy and IV Alteplase occur at the same time. While a patient is in CT, you're determining whether or not an angiogram is appropriate and determining whether mechanical thrombectomy is appropriate. Patients eligible should receive IV Alteplase even if mechanical thrombectomy is being considered. And I'll get into that a little bit later as well, unpacking that. And then patients at 0 to 6 hours of onset should receive mechanical thrombectomy with a stent retriever or direct aspiration thrombectomy if they meet the following criteria. So these criteria were developed by the Dawn and the Diffuse 3 trials that I'll get into. But pre-stroke modified Rankin scale score of 0 to 1, causative occlusion of internal carotid artery or MCA segment of 1, age greater than or equal to 18, NIHSS score of at least 6, aspects of at least 6, and your treatment can be initiated within 6 hours of symptom onset. The Dawn and Diffuse 3 criteria were different trials that looked at specifically different criteria determining whether or not mechanical thrombectomy would be a consideration for patients. So these looked at patients within 6 to 16 hours of last known normal. They had an LVO in their interior circulation. The Dawn trial looked at a clinical core mismatch. So they looked specifically at the combination of NIHSS score and imaging findings, whereas the Diffuse 3 looked at a perfusion core mismatch and looking at the maximum core size as imaging criteria to select patients. Lastly, anti-platelet therapy is listed in the guidelines. If a patient cannot meet eligibility for thrombolytic therapy or mechanical thrombectomy, usually the administration of aspirin is recommended in patients with acute ischemic stroke within 24 to 48 hours after onset. And is usually held for 24 hours post Alteplase treatment as well. In patients presenting with minor non-cardioembolic ischemic stroke, so your NIHSS score less than or equal to 3, who do not receive IV Alteplase, our chance and point trials kind of give us some guidance on whether or not dual antiplatelet therapy with aspirin and clopidogrel is appropriate. And so these guidelines recommend that you start those within 24 hours after symptom onset and continue for 21 days. Depending on the institution and who you're working with, this can change, but these are what the guidelines recommend. And ticagrelor is not recommended over aspirin due to the results of the Socrates trial. Lastly, for the ischemic stroke guidelines, I'll talk about blood pressure management. Post-Alteplase and mechanical thrombectomy, blood pressure should be maintained at less than 180 over 105 millimeters mercury for at least the first 24 hours. And part of this is looking at their neurologic and blood pressure assessments very often. So, at our hospital, patients are admitted to the ICU after given TPA due to the frequent monitoring that's required. So every 15 minutes for 2 hours, every 30 minutes for 6 hours, and then hourly until 24 hours have passed. Nurses and others are managing their blood pressure and neurologic assessments. Per the guidelines, the antihypertensives of choice are labetalol, IV pushes, and nicardipine infusion. The guidelines list clofidipine, but there is a caveat with clofidipine. It's a fat emulsion and can, kind of act a little bit differently than the other antihypertensives. I'll briefly get through the intracerebral hemorrhage guidelines for stroke that were published in 2015 by AHA and American Stroke Association. For the diagnosis, neuroimaging is mandatory and CT is gold standard. Like for ischemic stroke, CT is adequate to determine whether or not hemorrhagic stroke is on the differential. And of course, time, cost, and proximity to the ED and sensitivity, point all toward the CT being gold standard. These guidelines are broken down into different management of different complications that could cause the hemorrhagic stroke. So I'll go through those briefly. Patients with coagulation factor deficiency or severe thrombocytopenia should receive appropriate replacement, and the appropriate replacement will be as follows. Patients with a hemorrhagic stroke whose INR elevation is caused by warfarin should have their warfarin withheld and receive therapy to replace vitamin K, whether that is through IV. Recombinant factor 7A is not recommended for warfarin reversal in intracerebral hemorrhage per these guidelines. NOACs should be reversed with PCCs according to these guidelines. NOACs do have novel therapies to reverse. So dabigatran has Praxbind or Adaracizumab, Rivaroxaban and Apixaban have Indexa or Indexanet alpha. There's currently literature that's pretty controversial on whether or not these therapies are any better than PCCs, but these guidelines haven't been updated since 2015, and this literature is still coming out. Most recently 2018, 2019, 2020, there's been a ton of focus toward PCCs versus these novel reversal agents. Protamine should be considered for heparin reversal if heparin is the offending agent. As far as Dvt prophylaxis, these patients should receive SCDs on the first day of their hospital stay, and then initiating Dvt prophylaxis with Lovenox or heparin should begin once the cessation of bleeding is documented. Intracerebral hemorrhage requires intensive blood pressure lowering treatment. So with patients presenting with a systolic of 150 to 220, acute lowering of systolic to 140 is safe. However, you want to allow for permissive hypertension for the first little bit to help with cerebral perfusion. If their blood pressure is greater than 220 systolic, you want to consider aggressive reduction of blood pressure with continuous IV infusion. The guidelines recommend nicardipine with frequent blood pressure monitoring. For the next assessment question, which of these is an absolute contraindication to IV Alteplase use in acute ischemic stroke? It's B. A, C, and D are relative contraindications. For the next part of the presentation, I will go through the literature that I reviewed for mechanical thrombectomy and acute ischemic stroke. The first study that I want to touch on was published in the New England Journal of Medicine in May of 2020, titled Endovascular Thrombectomy with or without intravenous alteplase in acute stroke, or the DIRECT-MT trial. This trial looked at 656 patients randomized in a 1-to-1 ratio to either mechanical thrombectomy alone or IV alteplase plus mechanical thrombectomy. And this was performed in 41 academic tertiary centers in China. Inclusion criteria include patients 18 years or older and occlusion of the intracranial segment of the internal carotid artery or of the first or proximal second segment of the middle cerebral artery, or both, that could be treated with IV alteplase within 4.5 hours of symptom onset. And they require an NIHSS score of at least 2. Exclusion criteria include disability prior to current stroke, defined as a score of more than 2 on the modified Rankin scale, and a contraindication to IV Alteplase according to AHA and ASA guidelines. I mentioned modified Rankin scale a little bit throughout the presentation, but this is one of the major outcomes that are focused on in these trials. And so I felt it was necessary to kind of go through what the modified Rankin scale is and what it refers to. This is a scale that looks at functional status and disability. 0 being normally functional, having no disability at all, and 6 being death. And so the higher the scale is, the more disability patients have. The primary outcome for this study was looking at the score on the modified Rankin scale assessed at 90 days. And they used a window of plus minus 14 days after randomization. And this was analyzed for non-inferiority. The secondary outcomes, I won't read them all out to you, but they're looking at different scales of functional status that are different than the modified Rankin scale. And then safety outcomes include death, intracerebral hemorrhage, new infarction, pneumonia, and procedural complications. So as you can see here in this table, this lists the primary outcome, a median score with an interquartile range of endovascular thrombectomy alone versus Alteplase with endovascular thrombectomy. The median modified Rankin score was 3 in both groups. And so they determined there was no significant difference in the primary outcome of modified Rankin score. I listed all the secondary outcomes for reference, looking at modified Rankin score at 90 days, median NIHSS score, Barthel index, and then imaging outcomes, none of which were statistically significantly different in either group. This is the serious event or adverse event outcomes at 90 days, looking at the intention to treat population. Again, looking at those safety outcomes, there were no significant differences in either group, especially with bleeding or new intracranial hemorrhage. Author's conclusion for this DIRECT-MT trial was that the benefit of utilizing IV thrombolytic therapy in addition to thrombectomy cannot be ruled out. They looked at stent retrieval only. They looked at standard Alteplase dosing and no tenecteplase. And this is also a Chinese population, which makes it difficult to generalize to all patients that are treated. I think the benefit of using IV thrombolytic therapy may not outweigh the risk, especially when you think about the marginal benefits of increased perfusion and the cost of IV Alteplase, like I mentioned, is almost $10,000 a vial wholesale acquisition cost. It can also, add to potential for delay in care if a patient is directly admitted and know that they're eligible for mechanical thrombectomy, but you haven't ruled out all of the different contraindications for Alteplase. There is some risk involved there. Sorry. This table summarizes a few of the trials that I looked at for mechanical thrombectomy as well. The Dvt, the SCIP, and mechanical thrombectomy for acute stroke early versus late time window outcomes all looked at patients in thrombectomy versus thrombectomy and thrombolysis. The last trial that I mentioned looked at early versus late thrombectomy. So early being within 0 to 6 hours and late being greater than 6 hours, which is beyond the recommendation from the guidelines, all of which had around 200 patients. For the first study, the Dvt, the primary outcome was looking at that functional independence as defined by the MRS. 54.3% versus 46.6% achieved functional independence, and that is thrombectomy versus thrombectomy plus thrombolysis, pointing toward thrombectomy being more beneficial than both. In the second study, they looked at modified Rankin score at 90 days and found no difference in mechanical thrombectomy alone versus thrombectomy plus an IV thrombolytic. And then the last group, being the early versus late thrombectomy, they looked at modified Rankin score of 0 to 2 at 90 days. all patients. There were basically no differences. They looked at penumbral imaging based selection of thrombectomy and saw that that was effective regardless of onset and yields the same functional outcomes. So like I mentioned, the guideline recommendation for mechanical thrombectomy is patients at 0 to 6 hours of onset should receive mechanical thrombectomy with a stent retriever if they meet the pre-specified criteria. And then you ask the question, does new evidence provide suggestion to update the guidelines? 3 recent randomized controlled trials show marginal difference using thrombectomy alone versus thrombectomy plus IV Alteplase. And there's one retrospective study that suggests that mechanical thrombectomy still has some benefit after the 6-hour mark. And so in conclusion of the newest literature published, mechanical thrombectomy remains a standard of care, and IV Alteplase can be considered and has been proven to be relatively safe without significant added benefit. The next portion of the presentation, I'll review the literature published on tenecteplase. Tenecteplase is a tissue plasminogen activator like Alteplase, but the difference is it's genetically modified from human TPA and specifically has a little bit longer half-life than Alteplase. Alteplase half-life is around 4 to 5 minutes. Tenecteplase is around 20 minutes. Tenecteplase is currently approved by the FDA for the use in acute MI, and most recent guidelines suggest that tenecteplase is an alternative to Alteplase, specifically in the acute ischemic stroke guidelines. If Alteplase isn't available, then tenecteplase is a suggested alternative, but not the first-line agent. Current dosing for the use in acute ischemic stroke is 0.25 mg per kg IV times 1 dose with a max of 25 milligrams. And then adverse effects are very similar with bleeding and risk for cholesterol embolization, but it does not carry the angioedema risk that Alteplase has. As far as cost, it's a little bit cheaper than Alteplase, around $2,000 wholesale acquisition cost cheaper. And then 340B is around $100 and $150 less expensive than Alteplase. The first trial that I want to touch on is a randomized trial of tenecteplase versus Alteplase for acute ischemic stroke that was published recently in the New England Journal of Medicine. This is a phase 2B trial that randomized 75 patients to receive Alteplase at 0.9 mg per kg, standard dosing for acute ischemic stroke, or tenecteplase 0.1 or 0.25 mg per kg less than 6 hours after onset of acute ischemic stroke. The inclusion criteria was a perfusion lesion at least 20% greater than the infarct core and associated vessel occlusion on CT. They looked at co-primary outcomes, looking at the proportion of the perfusion lesion that was reperfused at 24 hours, and looking at the extent of clinical improvement based on NIHSS score. On the table on your right-hand side of the screen, at the top you can see the primary imaging outcome saw a significant difference in the tenecteplase group. So they saw a higher percentage, around 80% reperfusion at 24 hours versus 55% in the Alteplase group. They also saw a significant improvement in NIHSS score between baseline and 24 hours. The next study I want to go over is tenecteplase versus Alteplase before thrombectomy for acute ischemic stroke, published in New England Journal of Medicine in 2018. This is the Extend IATNK trial. This trial randomized 202 patients eligible to receive a thrombectomy with Alteplase at standard dosing or tenecteplase at 0.25 mg per kg within 4.5 hours. Again, the inclusion criteria was the perfusion lesion at least 20% greater than the infarct core and associated vessel occlusion. The primary outcome they looked at reperfusion of greater than 50% of the involved ischemic territory or an absence of retrievable thrombus at the time of initial angiographic assessment. Non-inferiority was tested first and then superiority. At the top of table 2, you have the primary efficacy outcome looking at substantial reperfusion at initial angiographic assessment. The tenecteplase group had a 22% reperfusion rate versus Alteplase being 10%. They found this to be statistically significant in favor of tenecteplase. As you can see in the secondary outcomes as well, the modified Rankin scale was less in the tenecteplase group, which is better. Functionally independent outcomes were improved in the tenecteplase group, and then early neurologic improvement was no real difference. This table basically breaks down the NIHSS score distribution for Alteplase versus tenecteplase. There were no significant differences in the NIHSS score in either the Alteplase and tenecteplase group at 24 or 72 hours. The Extend IA TNK trial had a part 2 that was published in JAMA the following year. This trial randomized 300 patients that was eligible to receive thrombectomy and receive tenecteplase at 0.25 or 0.4 mg per kg within 4.5 hours. So they're really trying to dial down which dose of tenecteplase is more appropriate, 0.25 or 0.4. The inclusion criteria is the same as before: perfusion, lesion, and then associated vessel occlusion, with the primary outcome being substantial reperfusion of greater than 50% of the involved ischemic territory. So at the top of table 2, you can see the primary outcome, substantial reperfusion and initial angiogram. They also broke it down between rural and metropolitan patients. Of note, there were no significant differences in the primary outcome in the 0.4 mg per kg group versus the 0.25 mg per kg group, indicating that the lower dosage of 0.25 mg per kg of tenecteplase is equally efficacious to the higher dose of 0.4 mg per kg. The last group of studies that I want to go over for tenecteplase is a meta-analysis of 5 randomized controlled trials that looks at the evidence of tenecteplase for non-inferiority to Alteplase for acute ischemic stroke. This was a breakdown of the TNK S2B trial performed in the United States, Australian TNK in Australia, a test in Scotland, test in Norway, and then the Extend IA TNK trial was also included in this study. So you can see each trial, not including the test, had around a similar group of patients, most of them looking at different dosages of TNK. Most patients were around the same age. And all the other baseline characteristics that were evaluated were relatively similar among all of these trials. This first chart goes over the primary outcome looking at modified ranking score. You can see on the left-hand side the breakdown of the primary outcome looking at the different doses of tenecteplase. So the top being 0.1 mg per kg, then 0.25 mg per kg, and then 0.4 mg per kg compared to Alteplase. And so the further toward the left side of the chart, meaning that tenecteplase is preferred over Alteplase. And so you can see in the 0.1 mg per kg and the 0.4 mg per kg, there wasn't really much difference. You can see a little bit more favorability toward Alteplase versus, or tenecteplase versus Alteplase in the 0.25 mg per kg dosing. Again, this is a breakdown of outcomes very similar to the chart before. This was looking at functional status, NIHSS score compared between Alteplase and Tenecteplase. And again, the 0.1 mg per kg has some more favorability toward Tenecteplase, but the most favorability being at that 0.25 mg per kg dosing strategy. This is just another example of this is the 90-day modified ranking score. In this meta-analysis looking at Tenecteplase versus Alteplase. You can see here under the odds ratio on the left-hand side of the table, right to the left being more favorable to Tenecteplase and the right being more favorable to Alteplase. Tenecteplase is a little more favorable at improving 90-day modified ranking score. For the final assessment question, what is an acceptable dosing regimen for Tenecteplase and acute ischemic stroke based on the information provided today? See. I know that was a ton of information, but I think the conclusions that are important for this presentation is that mechanical thrombectomy and IV thrombolytic therapy remain the standard of care. You can't really rule out utilizing both IV thrombolytic therapy in conjunction with mechanical thrombectomy. It should be considered, and you should have that risk-benefit assessment whether or not you feel like the patient needs both. However, the studies show that mechanical thrombectomy alone is non-inferior to both. And then Tenecteplase is a reasonable alternative to Alteplase for acute ischemic stroke thrombolysis. The dosing regimen is substantially easier for pharmacists to recommend and nursing to administer. You don't have to worry about the 10% and wasting the 10 milligrams or worrying about how much you have to administer over what. And then there are some cost differences to take into consideration with Tenecteplase too. Tenecteplase is about $2,000 cheaper than Alteplase, comparing wholesale acquisition costs. And then the outcomes, like I mentioned earlier, there are in recent studies that show improvement in the modified ranking score and NIHSS scores after 24 hours and reperfusion of the areas of occlusion in patients receiving Tenecteplase. Anecdotally, I have seen some institutions switching over to Tenecteplase for using use in acute ischemic stroke, and so I think it's something that should definitely be considered. And this concludes my presentation. Are there any questions? Megan.